All right, guys, so today we're going to be covering peptic ulcer disease. Naming this chapter peptic ulcer disease only was kind of a misnomer because we're going to be talking about medications that are not just for peptic ulcer disease, but also for things like gastroesophageal reflux, heartburn, occasional stomach upsets. So we'll get going here. Here's your learning objectives for this week. Split them into 2 pages. Okay, so what is peptic ulcer disease? Peptic ulcer disease is kind of like this hole or crater that develops into the stomach lining, and it can be because of a lot of different factors. Typically, we get them in 2 places. One can be in the gastric section. The other one can be in the intestine or the duodenal. If your family has a history of gastric ulcers, you're more at risk for having gastric ulcers. Blood group O, smoking, tobacco, stress, and then of course infection with Helicobacter pylori. There's a couple of different medication classes that are always on my brain whenever I think about someone who comes in who's telling me that they've got this gnawing pain in their abdomen or in their stomach. I think about corticosteroids. I think about non-steroidal anti-inflammatories, also known as NSAIDs, and then I think about my platelet inhibitors. So if a patient's on any of these medications, it puts them at risk for developing an ulcer. So as you're looking at your patient and you're wondering what could have caused this? Is there something else going on? It might not be just something as simple as them having heartburn. It may actually be an ulcer in their stomach. So I told you that there's 2 different types. There's the gastric versus the duodenal. And then what I did here is just kind of gave you a side-by-side comparison of the 2. I will tell you that as we go through nursing and as we go and start treating patients in our practices, that being able to differentiate between a gastric versus a duodenal ulcer is a big deal. One of the biggest deals that I want you to know with these type of illnesses is that eventually both of these, if left untreated, can cause them to start to lose blood through the intestinal system. So what we tend to see is that patients who lose blood up here in the gut and then they puke, it'll kind of be bright red. Or sometimes if it's old blood, it'll come out in their vomit like little brown flecks. The other side is that it can come out the other side. And when it comes out the other side, we can see that those stools are kind of black and tarry. Maybe they've got streaks of blood in them too. Typically, blood that comes out the bottom that's got bright red, it's not from an ulcer, a duodenal or a gastric ulcer because it's too high up. Usually if it's bright red blood coming out the backside, that is typically a sign that someone's got maybe either a rectal fissure, a hemorrhoid, something like that. But bright red blood coming up this way is a huge concern for a potential gastric ulcer. Remember, sometimes we can't see blood in the specimens that we're given. And so what we have to do is that we actually have to send them to the lab and do a hemoccult test on them. When we do that hemoccult test, it'll tell us whether or not it comes out to be positive or negative. Typically, you have a little card about yay big. You flip the card open, you put some poo-poo on it, close the card, then you take it over to the lab. They flip the card over, open the back panel, drop a couple of reactive agents on that, and if it turns blue, that means we've got blood in it. So not always visible to the naked eye whether or not you do or you don't have a blood in it. I tend to worry more about gastric ulcers than I do duodenal ulcers. I'm worried about both of them, but these gastric ulcers can be pretty tricky. And one of the things that happens with a gastric ulcer is that it tends to turn into cancer more frequently than it does with a duodenal ulcer. Typically a gastric ulcer, it is a ulcer that is usually caused by NSAID usage. So if I have a patient who's taking a lot of ibuprofen, Advil, Mobic, those sort of things, I start thinking it, and then they come in complaining of abdominal pain, I think about gastric ulcers. With our duodenal ulcers, one of the things that always kind of goes ding, 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 that's a duodenal versus a gastric one, is that these patients are always eating. When they eat, they feel better. Versus my gastric ulcers, they're like, I can eat food, but the pain is still there. So the duodenal is like, I eat and I feel better, but the gastric is like, I can eat, but it really doesn't change the pain. So that's another one of those things that helps me to realize that, okay, there's a difference between the 2. The other thing about a duodenal ulcer is that H. pylori is usually the most common cause. So H. pylori is a pretty bad little bug, It's Helicobacter pylori, and it has actually figured out how to survive in your gastric system despite all the acid. Guys, I'm telling you, there's a lot of bugs that get into your system. E. coli, salmonella, campylobacter, all these different guys that can get into your system, but they cannot survive through the acidity of the stomach. But this guy can, which tells you it's a pretty bad dude. And we'll talk more about H. pylori here in a few minutes. So the other thing that we're going to talk about today is gastroesophageal reflux disease. I will tell you that there's a lot of people, whether or not you're age over 40 or not, who experience reflux or heartburn symptoms. Typically that acid after a good meal will run up and down the esophagus, cause a lot of burning, pain, hurt, chest pain. I have seen people with horrible GERD symptoms that look like they're having a heart attack. So again, not a benign symptom at all. We do want to address GERD. We want to address these heartburn issues that occur on a long time basis. If not, if we keep allowing the acid to run up the esophagus all the time without treatment, the cells that should be laid in there like a bunch of Legos all of a sudden begin to lay themselves back in there incorrectly. And then they develop this precancerous stage called the Barrett's esophagus. Barrett's esophagus is no joke, people. A lot of times what we do with those patients is put them onto a couple different therapies to help give the body time to heal itself. And then, just like a woman with a bad pap smear or a suspicious pap smear, we bring these patients with Barrett's esophagus back in every year, put a scope down their throat to look at their esophagus, because we're making sure that we're watching these changes that are going on in the esophagus, because if not, that can lead to esophageal cancer. Esophageal cancer has a very, very high mortality rate. The good news is that we do have some different treatment options, and as we kind of move into this like very specialized section of pharmacology, I do want to let you know that there are some non-pharmacological treatment methods that we do recommend for our patients who are having frequent heartburn or pain in their abdomen. Typically, we find that patients who have heartburn, GERD, tend to be a little more round around the middle. And so we always recommend losing weight. The other thing we recommend is that we don't want men, and it tends to happen with more with men, is, men will, or even women, they'll wear their clothes so tight around their middle that, like we get the muffin top and the muffin bottom. Okay, so it looks like a hamburger bun in there. Okay, we want them to loosen those constrictors around their waist. We want their pants to fit right. Okay, we want them to lose weight. Elevating the head of the bed. So they have these really fancy wedge pillows. You can get them at Bed Bath & Beyond or your favorite specialty store, but it'll have like a wedge, so it'll start off kind of small and it gets really, really big. And we have the patient lay on that at night so that they don't get that, so that we can use gravity to kind of keep the acid down. If they don't have the wedge pillow, the other thing you can do is you go get some bricks and literally elevate the bed. Or you can do the old lady trick and get a new mattress and get those ones that are adjustable. Oh girl, you'll never miss, you'll never go back. I'm telling you, it's an amazing bed. We want them to avoid fatty or acidic foods. We want them to begin to identify the foods or what they're drinking that's causing them so much GI upset. There are certain foods in your diet that are just going to cause you to produce more acid. Salsa. Who doesn't love salsa? But salsa has a lot of acid in it, a lot of that tomato acid, and so it'll run up and down the esophagus and can make someone pretty miserable. Eat smaller meals. One of my best tricks for patients is, and it helps to achieve, weight loss and also to eat smaller meals, is I say from this point forward, you're no longer eating off of the dinner plate. Instead, you're going to eat off of the salad plate. Helps to decrease the portion size. The plate still looks full, looks like you're getting a lot of food. You trick the brain, and then that's about as much as they need to eat. The other thing is too with smaller meals is that sometimes we'll have them eat smaller meals, but then have them eat more frequently. So we kind of have them eat like a hobbit, first breakfast, second breakfast, first lunch, second lunch, all those good things. Absolutely no food intake 3 hours before going to sleep, even if the bed is elevated and all that other stuff, we don't want them eating. And then tobacco and alcohol use. Both of those are known to excite the gastrointestinal system and actually cause the reflux to be worse. So for treatment for our peptic ulcer disease and our GERD, we have a couple of different medications. Some of these you're going to really recognize, guys. I want you, as part of your learning process, one of the things I want you to do is leave the kids at home, leave the husband, or take your wife, however you need to do it. And I want you to go spend some time in a local pharmacy. And then very simply, I just want you to go around and pick up the products that are in each of these sections that we're talking about and just go see what's out there. The antacid section, the gastrointestinal system at your local pharmacy is kind of fascinating. But when it really boils down to, there's only actually about 15 or 20 products that we can actually buy over the counter for our stomachs. But just knowing like what all the intricacies are about what's actually out there helps you to understand, one, what your patient was trying to treat themselves for, and then two, how best to treat you, yourself, and your family. Okay, so do spend some time at your local pharmacy just reading the labels and going, I did not know that. All right, so what I did here was I arranged the drugs kind of in a specific order. The reason I did it this way is because this is how I feel like my patients grab medications when they go to your local pharmacy, okay? So if they're having problems with their tummies, the first thing they grab is an antacid. And then I'm like, well, that didn't work. And then they go to the next thing, and then they go to the next thing, and then finally they come to their doctor, and then again, all the rest of them are by prescription only. So that's kind of how I divided this up today. I thought it would be fun. First medication up that I feel like my patient would grab if they had an upset tummy would be our antacids. So there's a couple of different substances. It's calcium, magnesium, and zinc. I'm sorry, calcium, magnesium, aluminum, and magnesium. Sorry, I get tongue-tied. So calcium, aluminum, and magnesium. These three medications all work towards helping to neutralize the stomach acid. They're fairly cheap. You can get them over the counter, but two things. They don't promote healing of any kind of ulcers, and then they don't eradicate H. pylori. I told you, H. pylori is a bad dude. It lives in a stinking acidic environment that kills most things. They work super fast, 10 to 15 minutes. I feel better, and they last about 2 hours. That's kind of a downside to that. You know these medications. It's calcium carbonate, it's Tums, it's aluminum and magnesium put together. That's Maalox or Mylanta. Just straight magnesia is milk of magnesia. So these are all the medications that help to neutralize the acids. The people who know, who really suffer from GERD or from severe heartburn, they know that the best place to put these liquid medications like the Maalox, the Mylanta, the milk of magnesia, they take those medicines and they stick them in the refrigerator on the door. Let me tell you why. When you wake up in the middle of the night and you have this horrible heartburn, the only thing you want is to like just put ice on it, right? So they take their antacid and they stick it in the refrigerator. And then whenever they need it, they get it out of the refrigerator, shake it up because these medicines will separate, shake it up really, really good, pour their dose, and then drink it back. Ooh, the cooling sensation as it runs down your esophagus and goes, psh, it's the best. So you can tell your patients for an added extra, oh my God, that felt so good, put those medications, those liquid medications in the refrigerator. Sorry guys, Tums are still Tums. Tums, Rolaids, those kind of things, they're still chalky and chewy or gooey. Yeah. If I have a choice, Maalox or Mylanta for me. We do have to be cautious. Again, these are medications they can just pick up off the counter. But if your patient has a sodium restricted diet, as in patients who have cardiovascular disease, this may not, if they keep taking these medicines over and over and over again, they can actually shift their electrolytes. Our renal patients are the same way. Our renal patients, because their kidneys aren't working right, can shift their electrolytes if they keep taking this stuff over and over and over and over again. They can get too much calcium in their body. You can actually get like kidney stones will be worse. You can get constipated. Patients can even get hypercalcemic if they have to keep taking these antacids without a proper balance. Patients who have hypercalcemia have headaches, urinary frequency, they don't want to eat, nausea, vomiting, and they just don't feel good. There is something out there called milk alkali syndrome. So basically what happens is that you force yourself into this alkalinic state because you've taken so many of these. I've seen this a couple of different times in my life. One, I saw it with a kid. He didn't like to eat a whole bunch, but he was always asking for milk, and so his parents would just hand him a glass of milk. And you know what? He developed milk alkali syndrome. He actually shifted his pH to be more alkalinic than acidic, got himself out of whack, and got really, really sick. The other patients I've seen do this, it was a 75-year-old male. He was having horrible heartburn, and so he kept taking these antacids and taking them and taking them and taking them. He wasn't having heartburn. He was having a heart attack. It was the chest pressure, the burning. He thought all that was related to his GERD, and it wasn't. He just kept taking them and kept taking them, and again, shifted his pH, went more alkalinic, and got very, very sick. So cautiously, we use these with caution. If we're using them and they're not working, we need to step up the therapy. How do we step up therapy? Well, the best way we step up therapy is we use our H2 receptor antagonist. So we talked about histamine 2, histamine receptors. We have histamine cell receptors are kind of like all over your body. Those are histamine 1s. Well, histamine 2 also exists, but they just primarily line the GI tract, and so they can actually cause like a reaction in your stomach similar to what you would see on your skin if you developed hives. So our H2 receptors, these are the drugs that help to reduce the volume and the acidity of some of the parietal cells. So they're just like, let's take the acid from here, let's bring it down here. The acid from here, let's bring it down here. Okay, that's what these guys do. They just to kind of suppress it a little bit. So the good news is that they have a use in helping to heal our duodenal ulcers. They'll help to heal those within 6 to 8 weeks, and then our gastric ulcers within 12 weeks. Typical patients who are experiencing a flare-up of their GERD, we want them to take these medications for about 2 weeks, and that's usually the best that we can get with those. We have to be cautious in our patients who have liver or renal disease, because with these patients, they're not going to process them out correctly. So when I say renal or hepatic disease, so when I say hepatic disease, I, as a nurse, am looking for any patient who has liver failure, who has hepatitis, who has cirrhosis. So when I do my social history and I'm asking these patients, like, how much alcohol do you consume a day? None. And they giggle or whatever. Or I'm like, I just don't believe you. We need to find out how much they're consuming and what they're consuming. Again, I tell patients all the time, I'm like, look, you're not going to get in trouble with me if you're consuming alcohol. I just need to know how much so that I make sure that I don't kill you. And usually when I say it like that, they're all like, oh, okay, listen, one time at band camp, and they confess everything. Renal patients, again, I'm looking for renal failure, renal insufficiency. I'm looking at some labs. Oh, I forgot to ask you about liver labs. What labs did you look for if you have a patient who you think might have a bad liver? Do tell me. Good, you should have said AST and ALT. All right, renal patients. So again, kidney insufficiency, chronic kidney disease, those sort of patients. Someone who only has one kidney, someone who has renal cancer. These type of patients, their renal system may or may not work correctly. Again, what labs am I looking for when I look at a renal patient? Good, you should have said BUN and creatinine because that's the correct answer. Again, we want to watch these patients really closely. So the H2 receptor medicines, these are the medicines that you know and love. They are sold over the counter. Most of these H2 blockers have the last name as Tidine, Tidine as your last name, as in cimetidine, famotidine, nizatidine, and ranitidine, or ranitidine, however you want to say that. All of these medications are over the counter with the exception of Axid. Axid has still held on to its patent. Most of these medications are therapeutically the same, and you get about the same amount of bang for your buck. I will tell you that we don't see a lot of cimetidine or Tagamet hanging out on the market anymore. We found out that it has a tendency, to mess with the liver more than the other ones. So because of that, it can actually change the way that we are. I promise you there's no one getting hurt. If you can hear the screaming in the background, my husband's waking the children up. This medication alters the way that we are metabolizing medications, And whenever it alters the way that we metabolize those medications, it can cause some hepatic toxicity. So just so you know, cimetidine not really out there very much. If you see it, you need to be worried, because a lot of times that medication plus other medications equals trouble. So one more thing about cimetidine, this is an off-label use for it. We found there was some research that came out probably 10 years ago that cimetidine, for whatever reason, has the ability to decrease herpes. Not like prevent an outbreak or anything, but it helps to control the outbreak. So a lot of research was done, and then there was some studies, and then it kind of went quiet. So I feel like in the next 5 to 10 years, what will happen is they'll bring cimetidine back, but they'll give it a new name, like herpes suppressor or whatever. I mean, like they'll give it some sort of like fancy name. They'll change their formulary a little bit, and then say, we found a new drug. And then you'll like look at the generic name, you're like, that's cimetidine, that's Tagamet. What's the deal? Anyways, but it was kind of weird. So patients who took cimetidine who had herpes had less outbreaks of herpes if they took the medication. It was almost like a suppressor. It's kind of weird. So one of the things I need to tell you about is that with H2 antagonists, we do not want to take this medication with any substance containing calcium, magnesium, or zinc. And the reason being is because when we take it with that medication, the calcium, magnesium, or zinc is like, oh, Pepsid, you're so cute. Next thing you know, they're all together. They're like hanging out, and then they are bound. And then the Pepsid's like, but I need to leave. I need to go and like suppress some parietal cells so that we don't have as much acid in here. And it can't get away because the substance containing calcium, magnesium, or zinc is holding on to it. So if we take an antacid and a histamine 2 at the same time, there's going to be a decreased effectiveness of that medication. Now, I'm going to be real honest with you here, people. I know that this is true because it's what the book says. It's what several resources say. I cannot explain Peptic Complete to save my soul. So Peptic Complete is a medication that is both famotidine and an antacid as one pill. If this is the truth, then I don't know how this thing works. So it's a mystery to me, but I know that this is true. And so I do my best to not have my patients take a substance containing calcium, magnesium, or zinc 2 hours before or 4 hours after they take their H2 antagonist. Okay, we're just going to leave it at that. So if we have a patient who comes in and we are not getting anywhere with the H2 receptor, with H2 blockers, then the next thing we want to like scale up to would be the proton pump inhibitors. So your proton pumps, the way I kind of imagine these, they're like little spigots in your body. They're going, and they're spitting out all this acid all the time. So what these guys do is they kind of go over to the pumps and they're like, just kind of cap them off, these little spigots. They're like, boop, let me cap that off. And that way we get a decreased amount of acid into the tummy. The good news is that they have a place in both our PUD and our GERD patients. For PUD patients, you gotta take them 3 to 5 days and then you start to feel a little bit better. Remember to tell your patients that. I can't tell you how many times I've looked at a patient and said, okay, so I see that the doctor prescribed you a Protonix or omeprazole. And they're like, yeah, I stopped taking that. It didn't help. Well, how long did you take it? 2 days. Took 2 doses, didn't feel anything. Okay. It takes 3 to 5 days in order for it to build up to have enough therapeutic benefit for you to feel the effects of it. Okay. For a duodenal ulcer, we'll heal it within 4 weeks. For a gastric ulcer, we'll heal it in 6 to 8 weeks. So we get a little more effective treatment for PUD, for peptic ulcer disease, when we're utilizing these proton pump inhibitors. For the GERD patients, it typically takes 12 weeks of patients to get everything suppressed back down to normal before we can take them off of it again. So 12 weeks for GERD. So patients for GERD may do better on the H2 antagonist versus patients with the peptic ulcer disease may do better with a proton pump inhibitor. What we can do with this medication is that we would definitely want to have them take it 30 minutes before their first set of food intake. Because if we don't, then the body is kind of like, the body's like, ooh, food, versus if we take it on an empty stomach and then say food, then the pumps are not as excited as they could have been. Other problems that happen with proton pump inhibitors is that it does affect our body's ability to be able to absorb calcium from our diet. So patients who are on this therapy for a long term, we're talking 6 months, a year, years, We actually have them take a calcium supplement with this medication in order to prevent them from developing osteoporosis related fractures. Excuse me. Proton pump inhibitors tend to end in the ending prazole, P-R-A-Z-O-L-E. So you have esmopril, lansoprazole, omeprazole, and raprazole. Sorry. But there's also one other one that I didn't put on this list that you're going to run into all the time, and that's Protonix. And Protonix's generic name right now is escaping my brain. I need more coffee. Pantoprazole. See, I told you I needed more coffee. Pantoprazole. That's the other proton pump inhibitor that you're going to run into pretty frequently. Prevacid, Prilosec, Pepothon over the counter, Nexium, Acifex, and pantoprazole are still require a prescription. All of them have about the same amount of efficacy. So as far as this is concerned, again, we have the same problem. Do not take this medication with any other substance containing calcium, magnesium, or zinc. So what I would typically tell my patient to do is we'll take the Prilosec, omeprazole, first thing in the morning, and then we'll take our calcium supplement at lunch. Okay, so that way we're separating them by 2 hours before, 4 hours after. Then we won't have a problem with the medication, competing with each other or binding to one another. H. pylori. So H. pylori is the devil for the stomach. Again, this is a bacteria that has figured out how to live in this highly acidic environment. It has found a workaround for the pH. Dude, your pH in your stomach, it could like melt metal, but this guy can survive in it. So what we found is that we had these patients who were coming in with this gnawing, burning stomach pain and couldn't get rid of it. Like we would put them on a suppressor therapy. We give them, we put them on a histamine 2 at nighttime. We put them on the proton pump inhibitor first thing in the morning. And we were dual therapying these patients. Couldn't get the freaking pain to go away. As soon as we took away the drugs, the pain would come back. So scientists developed a test. And the test is for H. pylori, Helicobacter pylori. What they found is that this bacteria, it's pretty complicated and it doesn't want to leave. So you have to have a test for it before you treat it. So it's the H. pylori test. They get it done. Then after that, you're prescribed a regimen of medications for 7 to 14 days. So typically what we see here is we have omeprazole, which is a proton pump inhibitor. We give them clarithromycin, which is a biotic and acts on one set of bacteria, and then we give them amoxicillin, which acts on a different type of bacteria. If there's any of those components that you're actually allergic to, we have another plan which doesn't contain any of the penicillins and contains the alternatives: omeprazole, bismuth, subsalicate. And for those of you who have been to the pharmacy already and have been looking at the back of pill bottles, that's Pepto-Bismol, people. Who knew, right? Metronidazole and tetracycline. So one of the cool things about Pepto-Bismol is that it actually helps to prevent an overgrowth of bacteria in your stomach. And again, I'm going to tell you something about Pepto-Bismol. Okay, the big giant pink stuff. Take that big giant pink jar and stick it in your refrigerator. Okay, that way whenever you take it, whether it's an upset stomach, diarrhea, whatever else however else that jingle went, it's cold. It feels really good on a hot tummy. All right. Other wonderful drugs that we need to talk about today, sulfocate. So with this medication, sulfocarfate, also known as Carafate. This medication basically kind of goes in and it makes like this gooey substance, and it goes in and it covers over the top of any of the ulcers, so that basically the body has time to kind of heal the ulcer itself. Patients tend to find this one very, very soothing. The only problem is it does cause constipation and it has a very, very short therapeutic half-life. And so because it has such a short half-life, you have to take the medication up to 4 times a day. So 4 times a day, no fun, but it works well. Another medication that you'll see out in practice for peptic ulcer disease would be misoprostol, also known as Cytotec. Again, helps to stimulate the gas, inhibits the gastric acid, and stimulates the production of like this mucus that covers everything. These sometimes are given to patients if we have to give really high dose non-steroidal anti-inflammatories or corticosteroids for a long time, and we'll give this medication in conjunction so that we actually don't get an ulcer. It does cause diarrhea and cramping. It is a category X. What does that mean? It means it can be used to terminate a pregnancy. So typically, just to let you know, like when we talk about medications, sometimes they kind of fall into two different therapeutic classifications. You'll see this medication used here today for nausea for the ulcers, but if we were in an OBGYN clinic, we would see this medication used for other things. So say that we have someone who had a missed abortion or a blighted ovum. We could actually have them take this medication PO, and then this medication would cause their uterus to evacuate the products of conception. We use Cytotec in labor and delivery as a little pill or a little vaginal insert, and they'll actually take it and put it up next to the cervix to make the cervix start to soften and to get it ready for delivery. So Cytotec has more than one use. In this instance, we're talking about it with peptic ulcer disease. The other favorite medication that you need to know about with GI patients is called metoclopramide. This medicine doesn't really do anything as far as like mucus protection, that sort of thing. It actually makes the stomach kind of like have more peristaltic action. It goes, it makes them go faster, okay? So basically the food doesn't have time to run back up and down the esophagus because, hey, it's not gonna hang it out. It's like, go on through, go on through, go on through. We'll tend to use this for patients who have peptic ulcer disease. We'll also use it for patients experiencing nausea and vomiting. The other indication for this one is a problem called gastroparesis. Gastroparesis happens in patients who have diabetes that's been uncontrolled for long term. These patients, the nerve innervation into their guts gets really, really slow, and then their stomachs and their intestines just kind of go, and they just stop. Well, now you've got food and feces and everything else that's just sitting in the gut and in the intestines, and it's just not moving, okay? So they give this medication to help to stimulate the gut. Side effects, drowsiness, fatigue, confusion, insomnia. The biggest one you need to know about here is a condition called tardive dyskinesia. If you click on the link that I've provided to you, you can see an example of it. It's about a 5-minute example of all the things that happen with tardive dyskinesia. Basically, if you've ever seen a patient that looks like this, okay, and your thought to says, bless their heart, they can't stop moving. They can't. They're experiencing tardive dyskinesia. So with patients who are taking Reglan, they can develop this. They can develop a tremor or a hand gitch. They can develop symptoms that almost make them look like they've got Parkinson's, but then they can be even more severe because they just can't stop moving. Tardive dyskinesia is a movement disorder. Okay, so look it up on YouTube. It's it's sad and it's scary too. So if you have a patient who starts to have extra movements that they can't control whenever they're taking this medication, think about it, and then we'll take them off the medicine. Hopefully it'll go away. Sometimes if it doesn't go away right at the beginning, we'll give them Benadryl. That's right, good old-fashioned diphenhydramine. We'll give that to them, and that'll help kind of control some of the movement problems that they're having. Okay, so as a nurse, I'm getting ready to give one of these medications to this patient. What do I need to assess before I go in there and give them? I think by this point, you're kind of beginning to realize that this process is the same no matter where I go. So again, I'm looking at their health history, anything cardiac, anything renal, anything with their liver. Those are the 3 big ones that I always think about. What kind of medical history do you already have? Oh, I see here you have a history of GERD. Are you been taking anything for your GERD? Oh no, I took pills for like 2 weeks and it was gone. Well, when this pain started back up, did you start taking those pills again? Well, no, I came to the doctor. Okay, let's talk to the doctor about that. Ever had any surgeries? Other patients that can suffer from increased gastric issues, or those patients who've had gastric surgeries. So maybe they've had a lap band, maybe they've had a reduction in their stomach, maybe they've had a sleeve or something put on for weight loss. Those can all increase their risk of developing GERD. I also think about patients who've had intestinal disorders, whether it be cancer, or they've had part of their colon removed, or they've had something wrong. I want to make sure that they don't have any strictures that's not preventing everything from going through. Pregnancy. Okay, heartburn, unfortunately, ladies, whenever you're pregnant, it's just part of the game. So what medicines are going to be allowed for that patient? If the patient's breastfeeding and experiencing heartburn, what medications are allowed? What's going to go through the breast milk? We've already talked about the dangers of smoking, caffeine, drugs, and alcohol. Those can all increase our risk for developing both peptic ulcer disease and gastroesophageal reflux. What's your baseline vital signs? If I go in and I take the vital signs of a patient who's having abdominal issues, and they are tachycardic, have a high heart rate, or hypotensive, a low blood pressure, less than 90/50 or 90/60, I'm thinking that maybe that there's some sort of like incredible intense bleeding going on, and this patient may be in a lot more trouble than just having a little bit of a gastroesophageal disease or a PUD. Maybe they do have a bleeding ulcer, okay? I look at labs. So when I look at labs for these patients, I always start off with looking at their renal labs, looking at their liver labs, and then if I'm concerned about bleeding, I look at what's called a CBC or complete blood count, specifically targeting a hemoglobin and a hematocrit. I give the medications that was ordered by the provider, and I'm going to assess the effectiveness of this medication. Am I getting what I thought I was going to get? I'm going to repeat my vital signs somewhere between 30 minutes to 1 hour after I've given the dose. Again, checking on this patient, like, how you feeling? Is this working? Are we having any change? If they were hypotensive and tachycardic, I might check their vital signs more frequently. Are we having any kind of adverse effects? Okay, any confusion, numbness, tingling, heavy sedation, anything that I didn't think was going to happen. And again, looking at that therapeutic effect, am I getting what I thought I was going to get when I gave that medication? And then there's always safety concerns. Anytime I give a medication, a patient's never had it, I tell them, like, look, the first time you get out of bed, I want to know. Okay, let's talk about this medication before I just let you, drive a car. Okay, none of the medications that we talked about today, in my experience, have a lot of issues with sedation, but medications affect everybody differently. Like I said, I got this one family in town, talk to them all the time, love them to death, but sweet jinkies, they do not react normal to any medications. If it's supposed to be cause sedation, it's going to cause them to be wired. If it's supposed to be wired, they're going to cause them sedation. So you have to understand what is the safety concern with this patient. I know what the drug book says, okay? I know what the drug book says. But sometimes you really have to tailor those interventions to your patients. All right, listen, don't be a buckethead. If you have questions about this information, this lecture today, please make sure that you post a response.